Good morning, and welcome to Semel Institute Grand Rounds. I'm Andy Luchter. I'm a professor and executive vice chair of the Department of Psychiatry, as well as associate director of the Semel Institute. And it's my pleasure to moderate today's Grand Rounds presentation. It's also my honor to introduce today's speaker, Jeff Daskalakis. Jeff is the Igor and Joanne Grant Professor and Chair of the Department of Psychiatry at UC San Diego. He was formerly the Temerty Chair and Chief of General Adult Psychiatry at, excuse me just a second here, at the University of Toronto and CAMH. It's no exaggeration to say that Jeff has been an international leader in the area of brain stimulation treatments and development of novel treatments for major depressive disorder. He's been involved really in development of every major modality that we're currently using today, including studies of repetitive transcranial magnetic stimulation, magnetic seizure therapy. He's been involved in deep brain stimulation studies, in deep TMS studies, and he established Canada's first TMS clinical training program during his time at the University of Toronto. He's received more than $50 million in research funding as PI, initially at the University of Toronto at CAMH, and now has brought his research program to UC San Diego, where we are confident he will establish the department there as a leader in the area of brain stimulation research and treatment. Jeff is on the editorial board for Biological Psychiatry, Cognitive Neuroscience and Neuroimaging, as an associate editor for Clinical Neurophysiology as well. He's the author of more than 440 peer-reviewed publications and really is a giant in the field. And we're delighted that he's able to join us today to discuss the development of novel treatments for major depressive disorder. So with that, let me turn things over to Jeff.
Thank you, Andy. Pleasure to be joining you in Grand Rounds. Always excited to give Grand Rounds at UCLA. I recall several years ago having the opportunity to be down at UCLA, and at the time I was just fell in love with Southern California, and as Andy mentioned, I'm now well ensconced in Southern California, in the Southern California environment, having moved here and taken over this terrific department. The department actually didn't have much of a footprint in brain stimulation before I arrived, and it's now grown considerably, and I'll talk a bit about that later. I'll start with just giving you an overview of the of depression, treatment-resistant depression, the utility of TMS and treatment-resistant depression. Carry on with some of our recent trials involving TMS, our trials, plus some pivotal trials of others in the area of TMS. Then we'll talk about magnetic seizure therapy and our most recently published findings, and some of the trials that we're doing in magnetic seizure therapy. And then I'll conclude by telling you a little bit about what we're doing here at UCSD. So I will start by sharing my screen. So as you all know, depression is a leading cause of global disease burden worldwide. It costs society about $250 billion a year to manage. It leads to considerable functional impairment and affects millions across the planet. And specifically, major depressive disorder is a leading cause of suicide, unfortunately, with 40,000 Americans dying by suicide each year at least, and that number keeps growing proportionally, with an average of at least 100 suicides a day. In fact, it's a little bit sobering to know that during the 1 hour that we give this talk, someone will die by suicide in this country. More than half of suicides involve people over the age of 45, and the World Health Organization estimates that in the last 45 years, suicide rates have increased by 60%. And despite, I'm not sure if you folks have seen some of the recent criticisms that have emerged, but despite billions of dollars being poured into mental health research, the fact is that we've made very little impact or dent in the overall suicide problem that we're facing worldwide. And after accidents, suicide is also the leading cause of death in the US amongst those between the ages of 15 to 34, which is one of the most sobering statistics we can look at. We know that suicide emerges as a result of treatment-resistant depression, and oftentimes we fail to recognize what truly is treatment-resistant depression, and that is patients who are not responding to medications. And we don't typically consider that as being treatment-resistant. In many clinics that I've been part of, the notion of what treatment-resistant depression is as a separate phenotype isn't taken into consideration. It's often seen as just a failure to depression is often seen as being an illness that doesn't necessarily respond to medications, as opposed to seeing treatment-resistant depression as being a distinct phenotype of depression itself. And the phenotype is not small; it's large. It's 2.5% of the population. It's about a third of the overall depression population, with patients being more likely to be hospitalized, more likely to receive psychiatric medications, and the healthcare costs of treatment-resistant depression are about 2/3 of the overall cost of treating depression. And patients who respond often realize, which is another thing to take into consideration, even though our trials suggest that up to 2/3 of patients respond to medications, a significant proportion of those patients will fail to respond at least at 2 years. And so the size of the population being affected by treatment-resistant depression is quite large. So this is Corey Weissman. Many of you don't know Corey yet, but Corey is actually was my trainee in Toronto. Spent 5 years in the clinician scientist training program in the residency in Toronto. Did a lot of very interesting trials with me, and is actually joining us here at UCSD in about a month. And Corey published this important paper, well, something that we looked at carefully, and that is, you're all familiar with the pivotal STAR-D trial that was published in the middle part of the last decade, which suggested that about a third of patients are not responding to antidepressant medications, and that specifically is in the level 3 and level 4 steps. What Corey did, and this took at least 5 years, which was to go back to the archived STAR-D data and extract the suicide item from the Hamilton in that data set, and then look to see what were the effects of antidepressants on suicidality, specifically as part of the STAR-D trial. What he was able to demonstrate was that there was little to no benefit after 2 failed trials of antidepressant medications on suicidality. That is, if you did not respond to, if you had suicidality, the likelihood that you were going to respond, your suicidality was going to improve in any way, shape, or form beyond 2 trials of antidepressant medications was almost 0. And it's a very sobering statistic, considering that we often see patients who have suicidality, and we often put them on trial after trial after trial of medication. The data is quite sobering, and suggests that if you have suicidality at baseline, your likelihood of responding is lower. And it also suggests that if you fail to respond after at least 1 or 2 trials, the likelihood of responding is considerably lower. And so just the sheer presence of suicidality as part of your depression is actually a considerable risk for obviously completing suicide, but it's also a considerable risk for not responding to medications. And so we have one of the most effective treatments in medicine at our disposal. We use it all the time, albeit at a very small level. And that is ECT, of course. And ECT works on depression about 60 to 80% of the time, produces remission about 60 to 80% of the time, and it produces remission of suicidality more than that. And so this is one of the few treatments that we have in psychiatry that actually saves people's lives when they're experiencing suicidality, something that is often overlooked. And yet it is one of the most controversial, stigmatized, vilified treatments. It is so because of the way it's been portrayed in the media, but it is so also because of the cognitive side effects that patients experience. So much so that only about 1% of patients with treatment-resistant depression, not depression, but 1% of patients with treatment-resistant depression receive ECT. We often reserve ECT use for those patients who are quite severely affected, often have suicidality, and so this is a treatment that we use. Oftentimes, sometimes not with a great degree of an academic approach. In other words, there's inconsistency in the way we prescribe ECT. There's inconsistency in the way we use ECT in the context of severe psychiatric illness in relation to medications. And yet we have this treatment that works very, very effectively in our patients. We just don't use it enough. And part of the reason we don't use it enough, I also think, is because it's an old treatment. And you know, as we're watching the world innovate and develop, the idea that in psychiatry we're turning to a treatment that is 70 years old, I think gives us a bit of pause. It gives us some cognitive dissonance because it remains an effective treatment, and yet having more innovative, useful treatments at our disposal, treatments that are not associated with the same degree of cognitive side effects, I think is warranted. And that's where TMS comes in, of course. So TMS involves stimulation of the prefrontal cortex for therapeutic purposes in patients with depression. TMS can also be used for a variety of neurophysiological uses, but for the purpose of this talk, I want to focus squarely on TMS as a treatment for depression. And 20 years ago, I would give a talk on TMS for the treatment of depression. No one had heard about it, and nowadays it's become delighted to say that the uptake has been enormous around the globe. One of the most effective new innovations that we have at our disposal. And yet it is still also underutilized. So TMS works by depolarizing the current, the neurons in the cortex. At high frequencies, we see changes in neuroplasticity and changes in local connectivity. At low frequencies, we typically see decreases in local cortical activity and decreases in plasticity taking place in the cortex. And the way that it functions is it basically creates a magnetic field which causes depolarization of neurons through transsynaptic elements. The original data that was published showing that TMS had efficacy in depression was this pivotal paper that was published back in 2007 by John Earhart and colleagues. It came out of a neuronetics company called Neuronetics, which produces the Neurostar device. And the data at the time were somewhat controversial, promising, but also a bit sobering. I consider them sobering because what you can see here is you see therapeutic efficacy that was statistically significant, at least at week 6 and at week 4 in the case of response rates, and yet nowhere near as close to the efficacy that we see in depression. You see remission rates hovering around 15% as opposed to the 50 to 75% remission rates that we see with ECT. Despite that, it was promising, and we saw FDA approval of TMS for the treatment of depression. There's been a number of meta-analyses that have been conducted. I'm including an older meta-analysis here by Marcelo Berlin back in 2014, which suggested that TMS produced response rates that were hovering around 30% and remission rates that were hovering around 20%, based on a number of treatment trials that have been published to date. There have been several other meta-analyses, including a meta-analysis by Andre Bernoni a few years ago, also demonstrating considerable evidence of efficacy of TMS. We published a paper way back in 2016, and in that paper, the trial itself included 121 patients with treatment-resistant depression. We included patients with a Hamilton 17-item Hamilton score of over 20. And we did a few things that were considered novel at the time, including targeting the dorsolateral prefrontal cortex through cortical co-registration, including adjusting the intensity of the field magnetic field for coil to cortex distance, in other words, accounting for the variance that takes place between the motor cortex and the dorsolateral prefrontal cortex. This was one of the first trials that extended the acute treatment duration in the context of a clinical trial to 6 weeks. And despite all of those optimizations, we saw about the same degree of efficacy that we saw with Marcello Berlim's meta-analysis, and that is remission rates hovering around 20%, but only for bilateral ECT. And unilateral ECT, the FDA-approved treatment, actually did not differentiate from sham. Now, we also followed up, and this was one of the first trials that Corey published with me, followed up on that trial, as well as a previously published trial involving similar methodology, looking at unilateral versus bilateral stimulation compared to sham. And we combined those two trials to look specifically at the change score in the suicide item on the 17-item HAM-D. And what we found was that, as I mentioned, depression rates were hovering around, remission rates were hovering around 20%. Remission rates in suicidality actually were magnified by two times. In other words, remission rates in the bilateral treatment were up to 40%. The unilateral and sham, again, did not differentiate, but bilateral TMS was shown to produce significant rates of remission of suicidality, upwards of 40%. So these data suggest that TMS is an effective treatment, of course, for depression, but they also suggest that there may be a specific benefit of TMS for suicidality. Since then, there have been a number of innovations in the types of coil that are being used, and the type of coil being used, and also the patterning of stimuli. And one of the novel coils, although now it's well over 20 years old, is this deep TMS coil that was manufactured by Brainsway. It's an FDA-approved device here in the US. And that coil was originally designed with the intention of getting into deep brain regions. But what it also does is it produces a significant amount of cortical activation across the entire surface of the cortex. These are just data confirming that with the deep TMS coil, what you see is in purple colors, you see the significant decay of the magnetic field the further you are from the cortex. By contrast, with the deep TMS coil, you see a significant preservation of the magnetic field as you extend further and further out from the cortex, suggesting that, in fact, the magnetic field has significant action in deeper brain regions. It's not clear what those effects are vis-a-vis different psychiatric disorders, but we've now seen an emergence of these treatments not only for depression, but also for OCD. And so the question remains as to what's the mechanistic understanding of DTMS, and how does it target different brain regions to achieve its therapeutic effect. This was one of the first papers that was published on deep TMS for the treatment of depression. And these data were quite promising. You see response rates that were larger than what we'd seen before in our meta-analyses, response rates ranging between 25 to 35%, maybe even higher, and upwards of 38% per protocol analysis. This was in unipolar treatment-resistant depression patients. Now, as I mentioned before, the question of the neurophysiology of depression, and specifically treatment-resistant depression, has emerged. And we tried to weave in a clinical trial based on some of our physiological findings that we published over a decade ago. And these data suggested that there were, in fact, GABAergic inhibitory abnormalities that took place in patients with treatment-resistant depression. And the spectrum of these GABAergic abnormalities was much higher in the treatment-resistant depression sample compared to the non-treatment-resistant depression sample. I won't get into all the details of these data, but it suggests that there were both GABA-A and GABA-B physiological abnormalities in treatment-resistant depression compared to non-treatment-resistant depression, which remained confined to the GABA-B receptor mediated mechanisms. These data we also thought were important because we know that ECT as I mentioned, a routine treatment for over 7 years in patients with resistant depression, primes GABAergic neurotransmission. And so it may very well explain how both ECT works and what the targets are of ECT, although that question still remains unanswered. We followed up on those original data by, and again, these are old data now extending back to 2006, 2007. And what we demonstrated was that as we stimulated with higher frequencies of TMS, we saw this extension of inhibitory neurotransmission. In other words, with higher and higher frequencies of TMS, we saw a potentiation in long-acting inhibitory neurotransmission in the cortex, suggesting that higher frequencies may, in fact, potentiate LTP in the cortex, but they may also potentiate LTD-like inhibitory mechanisms in the cortex, which is important to understand. We followed those data up several years later in this paper by Danilo De Jesus, who was a postdoc in my group. And what we demonstrated in this paper was that we established in the previous paper that high frequencies, including frequencies up to 20 hertz, produce significant inhibitory changes in the cortex. In this paper, what we demonstrated was that you actually needed upwards of 6,000 stimuli to consistently produce those inhibitory changes. In other words, there may be, in fact, a dosing effect that has taken place with TMS in the cortex. And that question nowadays is starting to be looked at very, very carefully with the advent of these new accelerated approaches. But at that time, no one really considered TMS to be a dose-like phenomenon. And here was an example, one of the first examples of when you extend the treatment duration, you could consistently produce inhibitory physiological changes that took place, which were in the opposite or therapeutic direction compared to what we saw with treatment-resistant depression patients in our neurophysiological studies. And so we extended those data out in this sample, in this paper that was published a few years ago now. This paper was looking at deep TMS for patients with late life depression. Now, I'll get to the key aspects of this trial, but just in a second. But just remember that we had established, at least in our physiological studies in healthy subjects, that you needed 6,000 pulses to consistently produce a physiological change. In addition, because of the depth of the H coil, we decided to use the H coil specifically because we know as you age, you have greater cortical atrophy. And so we decided to use the H coil in partnership with Brainsway and some investigators from Ben-Gurion University to look at longer treatment durations of deep TMS in patients with late life depression. What we found here was quite promising. What we saw was a significant proportion of patients remitting with the deep TMS coil in patients with late life depression. And you can see here that the results are more robust than what we see with standard TMS coils in normally aged adults. And in our intention to treat sample, you see in the proportion of patients who were remitting, it was close to 40%. And in the per protocol sample, we were close to 50%. And similarly, in the proportion of patients who responded in the intention to treat sample, we see over 40%. And again, in the per protocol sample, in the proportion of patients who responded, well over or over 50%, which suggests that either the deep TMS coil or the extension of the treatment train may have been a major contributor to the enhanced therapeutic efficacy that we see in this trial compared to previous trials. There is another type of stimulation that we can use. It's known as theta burst stimulation. Theta burst stimulation was originally published by John Rothwell's group back in 2005. This was a paper that was published in Neuron. And what you see here is this two types of theta burst stimulation. I know there's three on the screen. I'm going to focus on the top one and the bottom one for now. Two types of theta burst stimulation that can be used to change physiology in the cortex. The first one is intermittent theta burst stimulation, which includes a triplet pulse delivered at 50 hertz for 2 seconds on, followed by 8 seconds off. And that intermittency of the theta burst stimulation was shown to produce significant increases in LTP-like plasticity in the cortex. By contrast, continuous theta burst stimulation, which does not involve the 8-second pause, a triplet pulse delivered for 40 seconds, 600 pulses, consistently produced LTD-like plasticity in the cortex. Now, why is this important? Because it's been demonstrated to be one of the most reliable methods through which to induce LTD or LTP-like plasticity in the cortex, but it also could have therapeutic implications. The first trial demonstrating that theta burst stimulation could be used as a treatment for depression was this randomized paper that was published in Brain in 2014. What they did was, I believe the study was involved between 60 and 70 patients, split into 4 groups. One group received continuous theta burst stimulation alone at 1,800 pulses, so 3 times that of the original Huang paper. Intermittent theta burst stimulation for 1,800 pulses, bilateral continuous theta burst stimulation delivered to the right cortex, to the right prefrontal cortex, followed or in combination with intermittent theta burst stimulation to the left frontal cortex, and then sham theta burst stimulation. And what they demonstrated was that in the bilateral continuous plus intermittent theta burst stimulation protocol, we saw significant therapeutic effects compared to the sham stimulation, but also compared to the continuous theta burst stimulation. So what we see here is a significant improvement in depressive symptoms in both the intermittent theta burst stimulation group that involved stimulation of the prefrontal cortex and the bilateral intermittent plus the continuous stimulation group. And these data actually are now being followed up in a considerable number of clinical trials across the globe. One of those trials that has been published back in 2018 was a trial that emerged as a result of a partnership between CAMH, led by Dan Bloomberger and Jonathan Downer at UHN. And it was called the 3D trial, which was a large clinical trial of 414 patients with major depressive disorder who were randomized to receive either the FDA-approved protocol, which involved 38 minutes of stimulation, 3,000 pulses, or the theta burst stimulation protocol, which involved 3 minutes of stimulation for 600 pulses. So patients were randomized, and the study was built as a non-inferiority design, meaning that we were attempting to establish equipoise between these 2 treatments. What was demonstrated is non-inferiority, and as you can see here, these 2 treatments were almost identical in terms of the therapeutic efficacy to one another. That is, that high-frequency left stimulation at 3,000 pulses for 38 minutes was nearly identical to theta burst stimulation at 600 pulses for 3 minutes, and that's Dan in the top left and Jonathan Downer in the top right of this photo. The data in relation to response and remission rates were quite compelling. We see a 50% response rate in ITBS and a 33% remission rate, and a 49% response rate and a 28% remission rate in the 10 hertz group. We've seen an emergence now. Sorry, just to go back to one key or a couple of key items. Number one, these data are perhaps some of the most compelling that we've seen in the TMS literature for a variety of reasons. First, it actually led to FDA approval of theta burst stimulation, which most of us are now using as a conventional treatment. And the reason we're using it is it's a highly efficient treatment. It only takes about 3 minutes to deliver this treatment. And if you extend it to 1,800 pulses, according to the lead paper, it takes a little longer than that. But the whole treatment can, for all intents and purposes, be done in about 10 minutes compared to the 38-minute treatment in standard TMS. And it's resulted in a sea change of using theta burst stimulation now for patients with depression. What is now emerging even more positively is the fact that you can get this treatment, the fact that you can take basically a 3-minute treatment or a 9-minute treatment, depending on how you you use it of theta burst stimulation, it's very short, and you can then pattern those treatments over the course of a day to achieve a better therapeutic effect. So that's exactly what Ellie Cole and Nolan Williams did in this published paper from a couple of years ago, from last year, sorry, which demonstrated that if you apply 1,800 pulses of theta burst stimulation every 50 minutes, 10 times a day over the course of 5 days, you can get whopping therapeutic effects. And these therapeutic effects are some of the best that we've seen in the TMS field, where you're seeing remission rates upwards of 80 to 90% and response rates that are also extraordinarily high, as you can imagine. And so what we're seeing here is a way of not only developing TMS to enhance its efficacy, but also to do it in a very short duration. In other words, your patients don't necessarily need to be struggling with depressive symptoms for 2, 3, 6 months. We're talking about a potential treatment that can produce a therapeutic effect in treatment-resistant depression in a matter of a few days. And so our hope, of course, this is now being evaluated in larger clinical trials. Our hope is that these data emerge to be some of the most innovative in our field and really transform the way we're treating depression. Along the lines of transformation of treatments, we know that a significant proportion of our patients will respond, of course, to medications. They will respond. If they don't respond to medications, they will respond to TMS. Depending on what the accelerated or SAINT protocol demonstrates, we may decide to end the presentation here. In other words, that we may not need alternative treatments. But time and time again, we've known that we need to turn to these seizure therapies, at least electroconvulsive therapy, for improved therapeutic efficacy. Now, as I mentioned earlier, ECT, some would consider an older, arcane type of treatment that is associated with side effects, although we've seen innovations in ECT that mitigate those side effects. Nevertheless, I think as a field, we need to continue to advance. And one of those significant advancements was made by Holly Listenby and her group that started over 2 decades ago now. And instead of using TMS to depolarize the cortex without producing a therapeutic seizure, the question that emerged was, can you depolarize the cortex through magnetic field to produce a seizure? Now, for the longest time, I actually wondered, why would you do that? Why would you, if we understand the efficacy of ECT in resistant depression, but why would you need to use a magnet to produce a therapeutic seizure? And the answer is that a magnetic field becomes more focal. The energy required to produce a seizure is significantly less, and it could result in significantly fewer cognitive side effects. Meaning that if you fail to respond to TMS, or for that matter, ketamine, which is also an emerging treatment, which I'm not going to necessarily talk about today, having convulsive therapies at our disposal to achieve better therapeutic benefits is important. Having convulsive therapies that do not produce cognitive side effects is of vital importance, and that's what we're hoping for with magnetic seizure therapy. So here's some data which suggests that the electric field changes that take place through magnetic seizure therapy are about a fifth, if not a tenth of that using ECT. And here's just a figure demonstrating that. You see here the hot colors represent considerable spread of electrical field throughout the brain, mostly propagated by neurons, but also by volume conduction through the CSF. With bilateral, bitemporal ECT. Here's bifrontal ECT, a significant proportion of patients getting deep brain regions affected, and as a corollary, cognitive side effects. With right unilateral ECT, we still see considerable activation, certainly on the right side, and some activation on the left side, which could account for some of the cognitive side effects. But with MST, what we see is very focused activation with little involvement of deep brain regions and potential sparing of cognition. So again, with Dan and with Jonathan, we embarked on a trial and we looked at different frequencies of stimulation. Stimulation intensity is fixed, but stimulation frequency had not been fully evaluated. And part of the reason for looking at different stimulation of frequencies with frontal MST was because there had been, at that time, some primate data showing that the sweet spot for producing a seizure was at lower frequencies. And so we looked at different frequencies. This was not in a randomized fashion. It was in a sequential fashion, an open trial of MST for treatment-resistant depression. In this particular trial, 108 patients were enrolled, 26 received 100 hertz, 37 received 50 or 60 hertz, and 45 received 25 hertz. Again, this was not randomized. We followed these patients in sequential order. And what we found was that high frequency stimulation produced the best therapeutic effects. You see remission rates hovering around 50%, remission rates over 30%, and response rates. I apologize. These are remission rates, and these are per protocol remission rates compared to a minimum of 8 treatments, meaning that up to 8 people who received fewer than 8 treatments were not included in this data. People received a minimum of 8 treatments. We saw remission rates over 30%. And in the per protocol, that is people who completed the trial, remission rates over 50%. In the high frequency group, 100 hertz, lower than that in the moderate frequency group, and lower than that in the low frequency group. Hard to know what accounts for this difference, but we do see this high frequency group remitting quite nicely with magnetic seizure therapy. Now, how about cognition? Well, this is a complicated slide. It demonstrates a number of cognitive tasks that were reported prior to and after a course of magnetic seizure therapy. We see some decreases, specifically in the AMI, and we see some improvements in the BVMT. Overall, we saw a neutral effect on cognition. The AMI we've since looked at carefully, and it is a cognitive task looking at the autobiographical memory, but it does tend to deteriorate over time. And in fact, if you look at some of the early work on the AMI using pharmacology, you see that similar degree of deterioration. In fact, the degree of deterioration that we see here with the AMI is comparable to other studies which suggest that the AMI deteriorates with time in the context of pharmacological trials. So we actually think that the effect of MST on AMI is neutral. By contrast, we see an improvement in other components of memory. And all told, I think what we've concluded is that magnetic seizure therapy has a very neutral cognitive side effect profile. And in fact, if you ask patients during the course of the trial, few, if any, actually reported cognitive side effects associated with magnetic seizure therapy. We looked at specifically at suicide rates using the Columbia scale, and what we found was that the lower frequencies actually produced better rates of remission of suicidality, uncoupling this idea that depression and suicidality go hand in hand. At least in our hands, we saw as I mentioned, lower frequencies being more effective in suicidality compared to high frequencies. We've since used these data. I don't have the data to show you, but we have concluded a trial or finished a trial of MST in depression for patients with borderline personality disorder, and in fact saw significant improvements in suicidality in that patient population. So there'll be more on that in the next few years. Those data were then used to fund or to support a larger trial of MST that is now taking place between UT Southwestern and CAMH. Our hope is that in the next few months, UCSD will come on board. Our target population is 260 subjects. And what we're doing is we're repeating this non-inferiority design, comparing magnetic seizure therapy to electroconvulsive therapy, specifically right unilateral ultra-brief electroconvulsive therapy. And our hope is that we'll be able to demonstrate that MST is clinically non-inferior to right unilateral ultra-brief. And I think this trial, if successful, will lead to FDA approval of magnetic seizure therapy for patients with resistant depression. This is a slight detour just to tell you that while ECT and MST are now, certainly with ECT and now with MST, showing evidence of therapeutic effects in patients with depression. We've known for many years that ECT can be very effective for patients with schizophrenia. And as a result, we published this very small pilot data on MST in patients with schizophrenia. And what we found, similar to depression, we found a significant improvement in resistant psychiatric symptoms in patients with schizophrenia. But we also saw this similar, what we think is a time degradation of autobiographical memory, and virtually no change in the MoCA, so global cognition remained preserved. And those data were subsequently used to extend funding for a larger magnetic seizure therapy trial in patients with schizophrenia. That trial, I was fortunate enough to get funded before I left Toronto. It's a 5-year CIHR-funded trial between 3 sites across Canada: CAMH, UBC in Vancouver, and London Health Sciences Centre. That target population is 160, and it's also built as a non-inferiority design, looking at patients with treatment-resistant schizophrenia. And so I'll conclude and take questions, but just to highlight a few things that we're doing here at UCSD. Our clinical structure is now being oriented so that we can really focus and attend to treatment-resistant depression and to some extent treatment-resistant schizophrenia, but mostly treatment-resistant depression. Our hope is that we can orient our services so that once we identify treatment-resistant depression patients, we can have those patients be treated either by our TMS or through ketamine. Of course, that relates to physician selection for the patient, but also patient preference. If those patients respond, then great, we can offer maintenance treatment to them depending on what their insurance provides. And the type of TMS that we're delivering is theta burst stimulation, bilateral theta burst stimulation, and we've even considered accelerated theta burst stimulation in a few select cases, although that's not being done routinely. Patients who fail to respond to either TMS or to ketamine, our hope is that they will eventually go on to get MST as part of a clinical trial, and we're building out our ECT services. Right now, we are offering right unilateral ultra-brief ECT as well as bilateral ECT. And if patients fail to respond to bilateral ECT, our expectation is that one day we may need to make available deep brain stimulation for those ultra-resistant patients. Currently, TMS is being offered both at our La Jolla outpatient services and also at Dove Canyon, which is our new TMS center here in Rancho Bernardo. In short order, we will have TMS also be made available in our downtown hub at Hillcrest, as well as Chancellor Park, where I think we're going to see more studies of TMS in both eating disorders, but also in eating disorders, in an eating disorder population experiencing significant depressive symptoms. So I'll stop there. Thank you for your time, and I'll pivot to questions. Perhaps we can start with questions in the Q&A, and then move.
Terrific. Thank you, Jeff, for a terrific talk and a wonderful overview of this broad field of brain stimulation. We have a number of questions from the audience here, and a few of them have to do with ECT. First question is, what does the field think about the use of ECT on non-treatment resistant but still moderate to severe depression, as opposed to using antidepressant medication first line?
On non-treatment resistant depression, but still moderate to severe depression. It's actually a good question. I think the same could apply for TMS, and that is, why should we be using medications when we can use TMS or ECT as a frontline treatment? The answer is, I think that it's a controversial topic. First, both ECT and TMS don't scale as effectively. We can do it in unique centers like UCLA, UCSD, academic centers that make this treatment available. But the idea of using ECT is going to be challenged by stigma, and it's going to be challenged by scalability. The other piece to consider is, are we actually benefiting from identifying those treatment-resistant depression patients? I'll explain what I mean. if you have patients who fail to respond to antidepressant medications, you may in fact be dealing with a different physiological phenotype, that responds more favorably to TMS or ECT. And so it argues for refining your phenotype towards a treatment-resistant depression sample to achieve better therapeutic effects. And we've seen a signal like that, not in the ECT field, but in the TMS field. And so I do think that or it stands to reason actually that there may be benefit from waiting for a couple of failed antidepressant trials before you pivot to either TMS or, for that matter, ECT. Quite frankly, I don't know if anyone would be willing to consider ECT as a first-line treatment, apart from those patients who are severely depressed, perhaps with suicidality, not eating, catatonic symptoms. I think there is a role in that domain.
Right. Okay, great. Thank you. Sort of a follow-up to that, Jeff, has to do with a reason that we frequently get consulted on the TMS service. That is, my doctor told me I should get either ECT or TMS as the next stage of treatment. I wonder if you might comment on situations which you might prefer ECT over TMS or vice versa, and specifically on the question of psychotic major depressive disorder.
Sure. I think that I think first we always take into consideration what people's insurance will cover, and we've seen some strange decisions by various insurers, some of which are very open and willing to approve treatments, others which have these I think misinterpreted rules. So a lot of it has to do with what insurers will approve. If you have a patient who would typically be approved in any other with any other insurer, or if you compare it to the literature, 2 failed trials of antidepressant medications. But we're now starting to see some insurers who are expecting 4 trials, at least 4 trials of failed antidepressant medications, including 2 augmentation methods, which we're now challenging. So some of it may just be a practical pivot to ECT because they're not able to get to be covered by the insurance for TMS. The other major issue is, as you point out, Andy, the psychotic depression or the severe depression with suicidality. I think the question of TMS and its impact on suicidality still needs to be determined, and we know the very positive impact that ECT can have on severe catatonia, suicidality, psychotic depression. And so in those very severe cases, particularly those patients who need acute treatment intervention in hospital, it makes sense to pivot towards ECT. Having said that, Nolan Williams data is quite promising, and we may quickly be rewriting our approach to these severely ill patients, particularly if we can get them better, as Nolan's data seems to imply, if we can get them better in a matter of a few days.
Right. Okay, great. Thank you. Looking at Nolan's data and looking at Dan Blumberger's data from the 3D trial, 600 pulses of ITBS is highly effective for the treatment of depression, non-inferior to 10 Hertz treatment. You take a look at the Lee data, it suggests that perhaps 1,800 pulses of ITBS would be better. And of course, in the Saint trial, Nolan's data would suggest that 1,800 pulses given very, very frequently have some superiority. Do you think that we can settle at this point on a minimum number of pulses of ITBS, or an optimal number of pulses of ITBS that we want to be delivering on a daily basis?
It's a great question. I don't know the answer to that. I mean, this harkens back to my original interest and passion, which is to look at physiological markers of response. We can certainly conduct relatively straightforward trials, at least in patients with depression, looking to see on an individual level what is the individual's response to those plasticity paradigms. In other words, if I have a patient with depression who comes in, I can quickly decide what is going to be therapeutic in terms of their what's going to be physiologically active, and then decide to use those physiological measures to inform what treatment they should get. We've not really hit that sweet spot yet. We haven't used the physiology, which is intuitively linked to the therapeutic potential of theta burst stimulation as a guide to what we should be using for therapeutic purposes. And my hope is that one day we'll get that sophisticated. It's not a far cry, even though it's a little bit more involved. It's not a far cry from what we do in other disorders, including diabetes, where we measure people's blood sugars, we decide how much insulin to give, and then we give the insulin at the appropriate dose. And so I can imagine one day that we'll decide that instead of using 600 pulses, we need to use 2,400 pulses to induce a significant plasticity effect. And that's how we ultimately should guide this treatment. But I'm not sure of that. I think it's an empirical question that needs to be determined. But I think that would be transformative. I think if we can start to tailor some of these or utilize some of these physiological tools to guide the therapeutic approach, at least insofar as pulses are concerned, I think that would be hugely beneficial. We have absolutely no idea what extending the number of pulses does to plasticity. We have absolutely no idea what extending repeated stimulation does to plasticity. We know there's some data that suggests that if you stimulate every hour for up to 3 treatments, at least in animals, and some early data in humans suggesting that can really significantly potentiate for prolonged periods of time plasticity in the cortex, which is quite promising and led to some of the accelerated work that's been done. But we have no idea what that does for 10 sessions. And for that matter, we have no idea what that does for 10 sessions repeated over 5 days. And I think these are all, I think, questions that are germane to our field and probably should be tested in a dose response fashion. Hopefully one day they will be.
Thank you. We have another question here about bipolar depression, and specifically somebody wondering if you could comment on the recent negative study by McGurr looking at ITBS for bipolar depression. The person goes on to say, although not compared to 10 Hertz treatment, can you comment on what their study suggested about potential different mechanisms of action with ITBS versus 10 Hertz, particularly for bipolar patients?
Yeah, I think for most of us in the field, when we originally saw this Alex McGurr paper, we were flummoxed. We didn't know what to make of it. And of course, if you're kind of a believer in the TMS field, these negative trials that occasionally come out, including from our own group, when we originally, that data that I showed you with the unilateral stimulation, we failed to find significant differences in the unilateral stimulation in 2 different trials. And so that was in unipolar depression patients. So how do I reconcile these data? And the short answer is it's actually relatively simple to reconcile. When you consider in ECT, we've known for many years now that if you use anticonvulsants or you use benzodiazepines in ECT, what you're doing is you are introducing a medication that has deleterious effects on your ability to induce physiological change in the cortex. We've seen that over and over again in early physiological studies. We've published on it, other groups have published on it. Using benzodiazepines, using anticonvulsants has a deleterious effect on your ability to produce the plastic changes that we think are needed for brain stimulation to work effectively. Now, when you think about those medications, think about the types of medications that you use for bipolar depression. The answer is you're using virtually the same. They're virtually the same medications. Oftentimes, with the exception of lithium, nowadays we see patients on antipsychotics, we see patients on anti-epileptics, and we see patients on benzodiazepines. All 3 of those types of medications have deleterious effects on your ability to produce excitability in the cortex, which is needed for therapeutic improvement. We've known that in ECT, and I think now we're starting to realize many of our bipolar patients who are struggling with depression are on these medications, and they, for all intents and purposes, prevent you from achieving a neurophysiological response, which is needed in depression. So what would I suggest we do? It's hard. It's very, very difficult. These patients are not responding to their anticonvulsants or to their benzodiazepines, and yet we continue these medications blindly, assuming that we are going to somehow worsen patients if we were to discontinue them. And the truth is that in the context of clinical trials, this is one case where I would love to see a clinical trial that did not involve medications as a potential confound. In other words, taking these patients with treatment-resistant depression who have bipolar disorder and removing all of these different types of medications and actually conducting a trial to see if they would improve. So the short answer is I think it was the medications that resulted in the negative trial effects.
Sure. Okay, great. That makes good sense. Thank you. Let's see, we have another question here about what data there are about TMS as a maintenance treatment after either on its own or after ketamine or an ECT response.
The TMS maintenance field, there's been several trials, including clustered trials, some maintenance trials, I think, and certainly after ketamine and ECT. These are all great questions. I would also love to answer the sham question because I think it's a good one as well. I think we're seeing TMS. The challenge with TMS is it's not widely used, and being able to offer medications is probably the simplest solution. Following a course of TMS treatment, ketamine treatment, ECT treatment, etc. But I do think that in short order, what we'll see is these different treatments being used interchangeably to maintain response after a more invasive treatment. But those maintenance trials just do not exist. I'm not, Andy, I'm not sure if you're familiar with any large-scale funding of maintenance TMS following an acute course, but I think these are all good empirical questions that we do need to test. As far as the sham question is concerned, there's a considerable amount to learn from sham. So we have a paper coming out where we specifically looked at the effects of or the sham placebo response rates in treatment-resistant depression. It's not out yet. I'm not sure when it's coming out. It's been accepted. I'm happy to circulate it when it comes out. But basically what we saw was that in treatment-resistant depression, the sham response rate is about 15%. So even in treatment-resistant depression, where you would expect a lower sham response rate, you still see a considerable one. And I think we need to take into consideration those numbers when we're doing some of these larger scale trials. You know, in our field, now that we have established treatments, I think the expectation of doing sham trials is going to be lesser and lesser. And we may need to use some of these meta-analyses of what a strong, or reanalysis of what a placebo response rates in treatment-resistant depression is, to be able to decide whether or not a treatment is effective without having to add to patient burden by randomizing them to a placebo.
Sure. Makes good sense. Thank you. And then last question I think we have time for today is, could you comment on the age effect of treatment response to rTMS as well as to MST? Sure.
The trial that we conducted, the MST trial, included people from age 18 to 85. I can't recall off the top of my head if we looked specifically at folks over the age of 65. I can tell you that it was a small number. So I'm not able to comment on the effects of MST. We've known for some time that ECT in patients over the age of 65 is a very effective treatment. Our data, I think I showed you data earlier on. I did show you data early on the TMS effects in late life depression. I think that's a patient population that's going to require careful study. The challenge in our field is once we have an established treatment in adults, extending those data to an adolescent population, extending them to a late life depression becomes difficult, both from a funding perspective, but also mostly from a funding perspective, and that is who's going to pay for these trials. Oftentimes, with pharmacological treatment trials, it usually was the industry partner who would pay for those trials. But these companies that are manufacturing this equipment don't have deep pockets like pharmacological or pharma companies do. And so we don't tend to see a lot of trials in these patient populations. So my hope is that we will see an emergence of data or data suggesting or see an emergence of data with subsequent FDA approvals for these specific patient populations, including geriatric depression. I think we're going to see quite favorable response, but that data is partly out yet, but not at the level of the 3D trial or at the level of the neuronetics trial, which were pivotal in getting FDA approval.
Right. Okay, great. Well, thank you. Thank you for the answers to the questions, Jeff, and thank you for a wonderful talk today. Many thanks to all of you for, pardon me, attending Grand Rounds. And Jeff, we look forward to being able to host you live at UCLA in the future.
Thank you all. Thank you, Andy, for inviting me.
Take care. Bye-bye.
Bye now.